Have you ever looked at the small print on a bottle of something you take every night and wondered whether the thing solving today's problem might be quietly becoming tomorrow's problem? I want to be honest with you right from the start. This is not a video telling you to throw anything in your medicine cabinet into the trash. I am not a doctor. I am not going to tell you what to take or what to stop taking. That decision belongs to the clinician who knows your full history. What I am going to do is walk you through 9 commonly used medications and medication classes that researchers have linked in large observational studies to an increased risk of developing dementia later in life. This is educational information. It is not a prescription. It is not a diagnosis. And it is not a substitute for personalized medical advice. Now, before we go through the list, I want to give you the framework because once you understand the framework, the list almost explains itself. And once you understand why, the information actually stays with you. That's the kind of knowledge that doesn't fade. Most of the medications we are about to discuss fall into one of 2 mechanistic families. The first family is what scientists call anticholinergic medications. Acetylcholine is one of the most important neurotransmitters in your brain. It is the chemical your cholinergic neurons use to communicate, and these neurons are heavily concentrated in the hippocampus, which is the structure responsible for forming new memories, and in the basal forebrain, which projects cholinergic fibers throughout the entire cortex. The cholinergic system is, in plain language, the engine of memory and attention. It is so central to cognition that, in Alzheimer's disease itself, the loss of cholinergic neurons is one of the core pathological features. And 3 of the main medications used to treat Alzheimer's symptoms are drugs that increase acetylcholine. So a drug that blocks acetylcholine on a chronic basis is doing pharmacologically exactly the opposite of what Alzheimer's medications are designed to do. A 2019 study published in JAMA Internal Medicine by researchers at the University of Nottingham, led by Carol Copeland, looked at nearly 60,000 patients with dementia and compared their past prescription records to over 200,000 matched control patients. They found that people with the highest cumulative exposure to strong anticholinergic medications, roughly the equivalent of 3 years of daily use, had nearly a 50% higher odds of being diagnosed with dementia compared to people with no such exposure. A separate study from the Indiana University Center for Aging Research found that nearly half of older adults take at least one medication with anticholinergic activity, often without knowing it. The exposure is widespread, it is hidden, and it accumulates. The second family involves medications that don't block acetylcholine directly, but that have been associated with cognitive decline and dementia through other proposed mechanisms: disrupted sleep architecture, impaired neurotransmitter function, vitamin B12 depletion, or chronic suppression of normal neural activity. We'll come back to exact mechanisms as we go through each drug. The reason I want to lay out the framework first is so that when I name a drug, you know not just what it is, but why researchers are worried about it. The drug is not the story, the mechanism is the story. Let me start with the medication most people have in their homes without thinking twice about it: diphenhydramine. Brand names: Benadryl, Tylenol PM, Advil PM, Zizquil. Diphenhydramine is a first-generation antihistamine. It was developed in the 1940s and has been sold over the counter for so long that most people treat it as harmless. It is not harmless, at least not on a chronic basis. First-generation antihistamines do not just block histamine receptors. They cross the blood-brain barrier easily because they are small, fat-soluble molecules. And once they are inside the brain, they block muscarinic acetylcholine receptors almost as readily as they block histamine receptors. So diphenhydramine is, in practical pharmacological terms, a strong anticholinergic agent that happens to be marketed as an allergy pill or a sleep aid. In the Copeland study, diphenhydramine was specifically named as one of the anticholinergic drugs associated with elevated dementia risk. The mechanism is not speculative. By blocking acetylcholine in the hippocampus and cortex, chronic diphenhydramine use is doing what I described earlier: pharmacologically pushing the brain in the opposite direction from where cholinergic Alzheimer's drugs try to push it. Multiple independent studies, including a review from researchers at the Alzheimer's Drug Discovery Foundation, have confirmed measurable cognitive impairment in regular diphenhydramine users, from slower reaction time to deficits in working memory. Second-generation antihistamines like loratadine, cetirizine, and fexofenadine were specifically engineered not to cross the blood-brain barrier in appreciable amounts and carry far less anticholinergic burden. This is not a minor swap. It is a structural pharmacological difference. Second on the list, amitriptyline and other tricyclic antidepressants. Amitriptyline was once one of the most widely prescribed antidepressants in the world, and it is still prescribed often now for chronic pain, migraine prevention, and nerve pain. It also has strong anticholinergic activity. In the Anticholinergic Cognitive Burden Scale, which is a tool clinicians use to estimate cumulative anticholinergic load, amitriptyline scores a 3, which is the maximum score on the scale, meaning it sits in the highest tier of anticholinergic burden. Studies, including a 2024 analysis in the journal Alzheimer's and Dementia, have found dementia risk elevated in users of tricyclic antidepressants specifically, more so than in users of newer selective serotonin reuptake inhibitors. The proposed mechanism is the same acetylcholine blockade, but it lands harder in older adults because blood-brain barrier permeability tends to increase with age, and cholinergic neurons decline naturally over the lifespan, making them more vulnerable to additional pharmacological suppression. This is not a reason to stop any antidepressant prescribed to you. It is information about why clinicians sometimes switch older patients to different agents when there is clinical justification to do so, and why the discussion of anticholinergic burden is increasingly part of modern geriatric prescribing. Third, oxybutynin. Brand names: Ditropan, Oxytrol. Oxybutynin is an anticholinergic medication prescribed for overactive bladder and urinary incontinence. It is one of the most prescribed drugs in its class, and it is also one of the most anticholinergic. Bladder antimuscarinics as a class have been repeatedly linked to dementia risk in large studies. A 2024 analysis using data from over 100,000 patients found that people treated for overactive bladder with anticholinergic medications like oxybutynin had a measurably higher rate of dementia diagnosis than those treated with non-anticholinergic alternatives, including beta-3 agonists like mirabegron. The mechanism is again cholinergic blockade. The interesting wrinkle is that, unlike diphenhydramine, oxybutynin is a prescription drug, which means a clinician has already determined that its use is medically indicated. The question researchers are raising is not whether oxybutynin works. It does. The question is whether alternatives that don't touch the brain might achieve the same bladder benefit with less cognitive exposure over years. Fourth on the list, long-acting benzodiazepines. Brand names include diazepam, marketed as Valium, and clonazepam, marketed as Klonopin, among others. Benzodiazepines enhance the activity of a neurotransmitter called GABA, which is the brain's main inhibitory signal. They bind to a specific site on the GABAA receptor and increase how often the chloride channel opens when GABA binds. The result is a generalized calming of neural activity across many brain regions, which is exactly why they work for anxiety and for sleep. The problem is that this calming is not selective. It affects the hippocampus, it affects attention networks, and it affects the systems responsible for forming and retrieving memories. A meta-analysis pooling results from 10 studies found that long-term benzodiazepine use in older adults was associated with a significantly increased risk of dementia, with the highest risk observed for long-acting agents. A 2025 population-based study reported an approximately 65% higher dementia risk in long-term benzodiazepine users, with long half-life agents showing roughly double the risk of short half-life agents. The contested part of this literature deserves attention. Some more recent analyses have argued that once you control for the underlying conditions that benzodiazepines are being prescribed for, particularly anxiety, insomnia, and depression themselves, the apparent association shrinks substantially. This is called confounding by indication. People who need benzodiazepines often have sleep or mood issues that independently raise dementia risk. Whether benzodiazepines are a true causal contributor or whether they are markers of an underlying condition is genuinely debated in the literature right now. What is not debated is that chronic benzodiazepine use in older adults is associated with measurable cognitive impairment, increased fall risk, and increased mortality. Again, this is not advice to stop a medication. It is information about why short-term use, the lowest effective dose, and regular review are the principles geriatric prescribing tends to follow. Fifth, Z drugs, primarily zolpidem, which is marketed as Ambien, along with esopiclone, Lunesta, and Zaloplan, Sonata. Z drugs act on the same GABAA receptor site as benzodiazepines, but they were specifically designed to target the subtypes of the receptor most associated with sleep, theoretically producing sleep without the broader cognitive effects. In practice, the theoretical promise has only been partially delivered. Studies have shown measurable cognitive impairment in older adult Z drug users within days of starting. and cohort studies have suggested that longer-term use may compound that effect. Sixth, proton pump inhibitors. Brand names: omeprazole, Prilosec, esomeprazole, Nexium, pantoprazole, Protonix, and others. PP is reduced stomach acid production and are among the most prescribed medications on the planet, with millions of long-term users. Several large observational studies have found higher dementia rates among long-term PPI users. A 2023 study published in Neurology followed participants over time and found that cumulative PPI use exceeding roughly 4.5 years was associated with a 33 to 38% higher risk of later dementia. A nationwide Danish study published in Alzheimer's and Dementia, led by Nels Perhati, found PPI use associated with elevated dementia risk, regardless of when treatment started, with effects more pronounced in users who began PPIs at younger ages. The proposed mechanisms are several, and they are plausible. Long-term acid suppression impairs the absorption of vitamin B12, magnesium, and possibly calcium. B12 deficiency is independently linked to cognitive impairment and to elevated homocysteine, which is itself a vascular risk factor for dementia. Some researchers have also proposed that PPIs may affect enzymes involved in amyloid processing, though that work is still preliminary. What I want to highlight is that PPI prescribing has become normalized in a way that may exceed what the evidence actually supports. Many people who start a PPI for short-term heartburn remain on it for years without reassessment. That pattern is what researchers are pointing to, not occasional use of the medication. Seventh, long-term opioid medications. Opioids act primarily through the mu opioid receptor, which is densely expressed in areas of the brain involved in pain perception and reward, but also in the hippocampus, which is the memory structure we have been talking about repeatedly for a reason. Chronic opioid use has been linked in multiple cohort studies to cognitive decline and to elevated dementia risk. A 2023 study in chronic pain patients found that long-term opioid users had a measurably higher rate of dementia diagnosis. Imaging studies in chronic opioid users have shown reduced hippocampal volume, which is exactly the kind of structural change that overlaps with early Alzheimer's pathology. A 2015 study by Sasha Dublin and colleagues at Group Health Research Institute found cognitive impairment patterns consistent with accelerated brain aging in long-term opioid users, including impaired working memory and reduced processing speed. Again, this is not a blanket statement about all opioid use. Acute short-term properly dosed opioid therapy for surgical or post-injury pain is an entirely different clinical situation than years of daily use. Eighth, gabapentinoids, primarily gabapentin and pregabalin. These are medications originally developed for epilepsy and nerve pain that have become enormously widely prescribed for everything from chronic back pain to anxiety to insomnia, particularly over the last 15 years. A 2025 study published in a BMJ Family Journal looking at chronic low back pain patients found that people who received 6 or more gabapentin prescriptions had approximately a 29% higher risk of dementia and an 85% higher risk of mild cognitive impairment compared to those who did not. A 2022 study found measurable neurocognitive decline associated with gabapentin initiation in older adults who had normal cognition at baseline. The proposed mechanisms involve gabapentin's modulation of calcium channel activity in the hippocampus and its interactions with glutamate, which is the brain's main excitatory neurotransmitter. The thing that has made gabapentinoids a particular concern in this conversation is the sheer scale of prescribing. Tens of millions of prescriptions are written annually, often for conditions where the evidence base is thinner than the prescribing volume would suggest. And ninth, inhaled anticholinergic medications for COPD, primarily tiotropium, Spiriva. A 2025 study published in JAMA Internal Medicine found that initiation of tiotropium in older adults with COPD was associated with a small but real increase in dementia risk over a median follow-up of roughly 7.5 years. The mechanism is the same cholinergic blockade we discussed at the top, just delivered through an inhaler rather than a pill. So that's the list. 9 commonly used classes of medication, each one with peer-reviewed observational evidence of varying strength linking chronic use to elevated dementia risk, each with a proposed biological mechanism, each with years of accumulated clinical experience behind it. Let me bring this all the way back to biology, because that is what this channel is about. Your brain is not a static organ. It is a dynamic, plastic, constantly remodeling system, and the chemistry it lives in matters. Every medication that crosses the blood-brain barrier becomes part of that chemistry for hours, for weeks, sometimes for years. Some of these medications are genuinely necessary, and the people taking them have clinical conditions where the benefits clearly outweigh the risks. Some of them, particularly certain anticholinergic and sleep medications, are being used in patterns that evidence suggests may not be optimal for long-term cognitive health. The choice of medication, the dose, the duration, the alternatives, these are decisions that depend on a specific person's full medical picture. The action item from this video is therefore narrow and specific. If you recognize any of these medications on your own list or on the list of someone you care for, that is a conversation worth having with a clinician who can review the full picture. It is not a conversation worth having alone in the middle of the night with a search engine. And it is certainly not a conversation that should end in anyone stopping a medication abruptly, because some of these drugs, particularly benzodiazepines, gabapentinoids, and certain antidepressants, carry real risks of serious withdrawal effects if discontinued improperly. The brain you are protecting is the same brain that is reading these words right now, that is forming the memory of this video, that is the substrate of every thought you will have for the rest of your life. It deserves the same careful, informed, mechanism-aware thinking that goes into every other high-stakes decision we make for it. If this video gave you a clearer picture of something that was previously just a vague worry, make sure you subscribe to the channel, and leave me a comment telling me which of these 9 surprised you most, or which one you have personally encountered. I'll see you in the next one.